I'm excited to move forward with that and just continue to move the needle on this topic and make Alzheimer's disease a rare disease.
Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent from developing and improve from suffering with brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a physician and Chief Scientific Wellness Officer at Kemper Cognitive Wellness, and I'll be your guide on these sound waves. So whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have a loved one with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's, dementia, and just generally things in life's second half. If you have questions or comments, check us out on social media. To support us, go to patreon.com/evolvingpast. And consider hitting the button and becoming a patron of this show if you find these episodes valuable. That's Patreon, Patreon, patreon.com/evolvingpast. So here we go. Let's get better. We're going to do almost a part two from last episode with Drs. Bredesen and Toups. In that episode, we featured a lot of the design and some of the significance of recently results that were published on MedArchive. And this was a clinical trial where, and I really have to call attention to this, 84% of 25 patients with early Alzheimer's disease or mild cognitive impairment improved with a precision medicine approach. And I'll say that again, just for emphasis, 84% of 25 people had some improvement, many of them quite marked improvement. And with that in mind, what we want to do is get another perspective from the other two physicians who led what I consider to be a very groundbreaking clinical trial. And in this episode, we're going to more emphasize the patient side of the story and get a little deeper into kind of what went on. And in order to do that, I'm going to introduce my guests here. First is Dr. Anne Hathaway. Dr. Hathaway's Dr. Hathaway's been treating people with a functional medicine approach since the mid-1990s. Over the last 5 years, she's really shifted her emphasis to a functional approach for the reversal of cognitive decline. Dr. Hathaway's been a lecturer and teacher for numerous high-profile organizations and has been also a previous guest on this podcast a few years ago where we talked about bioidentical hormone replacement, something about which Dr. Hathaway is really a scholar, and I've learned a lot from her in that regard. So welcome to the show, Anne.
Thanks so much. It's great to be here.
Secondly, I want to welcome Dr. Deborah Gordon, who's more of a recent colleague and friend of mine. She's graduated from University of California, San Francisco Medical School, boarded in family medicine, and for the past 25 years, she's had an integrative practice in Oregon, where she addresses medical problems by looking for root causes and helping patients find lifestyle solutions. She has a particular interest in Alzheimer's. Dr. Gordon can be found online at Dr. Deborah with an HMD.com or northwestmemorycare.com. Welcome to the show, Dr. Gordon.
Hey, thank you, Nate. Great to be here.
So let's get right into it. There's a lot to get through, a lot to talk about. So 84% of 25 patients improved. First, let me ask you, Anne, were you surprised that people improved?
Yes and no. I certainly expected some patients to improve because I'm working with this kind of patient day in and day out. It usually is a little slower to get people on board and up to speed to actually see the improvement. We saw improvement really pretty quick in these patients, and we can get into why that was a little bit later, because it wasn't just me taking care of these patients. It was a group. The support group was huge. But 84% is pretty darn impressive. Yeah, we had a health coach who literally did a home visit every week for the first 8 weeks. So it's hard to be not on task and on track when you have a health coach. We had a nutritionist who was doing interventions with them and making sure they completely understood what a keto diet was how to shop for it, how to cook for it. And our nutritionist did home visits if necessary and went through people's pantries and refrigerators. And then we had a trainer, physical trainer, who worked with people. Some people were in my group of 10 patients. Some people were avid athletes. Other people barely moved. And so we had to have a physical trainer who could work with people with injuries, people who are elderly, et cetera, et cetera. So the people in this study had an incredible amount of support and help to get to the optimal version of the protocol. There still were, bumps up and down,
Of
but
course.
with that kind of help, if we couldn't have had very, very, very good success, I would have been surprised.
Absolutely. It's still amazing, just that you could give those kind of resources. Deborah, I want to ask you for a second. Also, in kind of clarifying the lay of the land for the study, this is obviously an intensive study, and probably it doesn't necessarily, or might not necessarily reflect the usual care that you give your patients. I'm not sure. Whereas the care for the in the study kind of like different than your normal practice? And was that good, bad? I mean, neither. I mean, do you understand what I'm asking?
I do understand, I think, what you're asking. And along the lines, in addition, so in a way, they got the Cadillac of care, and I got the Cadillac of resources to decide what to do for them. So we had support for them to be tested in every way you could imagine within the first couple months of the study. And although there were some snags in the road, I had one patient whose Lyme disease testing didn't come back till 9 months into the study. Luckily, it wasn't too bad, and that wasn't a huge part of his illness. So we had all the testing done at the first. One of the things my health coach did, and I bet Ann's did too, one of the advantages of doing a home visit is they kind of had eyes on the ground. So if a patient says, I don't think my home is moldy, and my health coach says, oh, it was moldy, and we took a tour of all the chemicals in the bathroom, that just makes my job easier talking about things like that. I think some of the hard parts of the study, which is sort of a mixed bag. There were things that we decided as a group of clinicians that were important and we would do with them. So for instance, a study came out recently. I think I saw Dr. Sarah Gottfried posting about it, how mindfulness meditation helps people relax in the setting of Alzheimer's disease and can help cognition. And when we're working with individual patients, we might say, do you want to meditate? Here's some good meditation apps. Here's a good class. You could do it with this app. Well, in the study, everybody did it the same way. So I had one patient who was a lifelong meditator, and she says, well, I'm not going to get much out of this app. And she did, and it was great. She said, this is really different from meditation, and I love the feedback because we did heart math, and she could see her heart rate variability, so she loved that. And same thing, with the personal trainer. Oh, I exercise a lot. Well, have you ever lifted heavy weights? Well, no. So we got to push everybody a little bit out of their comfort zone, whereas if we were working on our own, and maybe Brain HQ, the brain training exercise, was the most vulnerable to this. Working on our own, I think all my patients would have bailed on that after a few months. But we kept telling them, no, you have to do it this many times a week. You haven't been doing it. The health coach and I were checking up on them. So it was exciting to have all this information. And sometimes it was overwhelming. Oh, my goodness. I have 24 abnormal labs to follow up on in this month's visit,
Yeah, it is overwhelming from both obviously from a patient perspective, but certainly from a clinician, as a doctor. Amazing. So I want to ask you one follow-up question there, Deborah. You mentioned some of the technology. So you mentioned Brain HQ, which is a sort of a brain training program online. You might call it brain games to some extent. You mentioned Heart Math, which is an app-based program to help people learn to breathe and train them into a state that you might think of as being more relaxed or health promoting, including heart rate variability or HRV. So, some people say, well, maybe this group of people couldn't handle technology. Is that? I mean, if you had to do it over again, would you have used Brain HQ, Heart Math, those pieces? I mean, did it work?
Yeah, it did work. I had one guy who said, "I can't do Brain HQ. I'm going elk hunting next week for 10 days." And he figured out how to download it on his phone, which, with a hotspot. I don't recommend it. That's not really great. But um, they they put up resistance, but they did it. And although I think I have more flexibility in my practice, partly because not everything's paid for my private patients, um, they got something out of it. And I think we didn't use the technology to its fullest availability. So, for instance, Brain HQ, we could have been getting data along the way as to how they were doing. And
Mm-hmm.
my office administrator did that a little bit, and some of the patients reported to me a little bit. But I think for most of them, it was great to have something. I'd say for 60% of them, it was great to have something that gave them a little feedback. Oh, your heart rate variability is really good. And then I had one patient who didn't ever like any of that. And he was very competent and he did it, but it wasn't his cup of tea. And if he'd been my private patient, I would have found something else for him to do.
Uh-huh. Okay. So interesting. So, and let me, and I don't know if you have anything to respond to that, but I did have sort of another question, because a lot
Well,
of people. Go ahead.
I had one patient who, a physician actually, who, when the pandemic started, which was a big issue, of course, in our
Oh yeah,
study, smack dab in the middle of the pandemic,
yeah.
she, her job went away and she had to start two new jobs. So she had to learn all this stuff for two new jobs. And she was trying to rebuild a house that had burnt down. So she had all these issues going on. And she stopped doing Brain HQ. And every time the health coach talked to her, and every time I talked to her, she said she was going to start doing Brain HQ again. She never did. She never did. And, maybe we should have taken her out of the study, but she did every other thing perfectly. She was a tremendous athlete, and she increased her she was just perfect on being in ketosis and doing heart math, and she really was strongly committed. She just couldn't do that one. So that is a weakness in the study, not to have some kind of alternative. On the other hand, how do you compare data when you have people doing different things? We have this Brain HQ data on all our patients, except for her, that where we can compare, say, their compliance. Eventually, we'll be able to look at the compliance data more carefully and see, okay, with this level of compliance, they did this much better, right?
Mm-hmm.
And you know, um,
So she
it,
might
it's a
not have done Brain HQ, but she learned two new jobs. That's pretty good cognitive
Exactly,
training. And
exactly.
did
She
she
was
do?
she
Did
was
she do?
definitely she was definitely challenged. She had to go into new situations, learn new protocols, etc. And she's an anxious person already,
Yeah,
um, which you know aren't most of us. But
especially in
anyway,
especially in 2020. Especially in 2020.
yeah.
Let me ask you another question, Ann. So I do want to get into some of the details of treatment. Can you kind of open up the can on treatment details and factors especially for people that were successful in the study?
Yeah, I mean, I think it's good to talk about people who are successful and people who weren't successful. And
Right.
I have my two favorite patients. One who was a woman who was an ApoE33, not a genetic increased risk factor, but she is someone who started cognitive decline. She noticed memory problems starting with menopause, and she, smart person that she is, got herself on an estrogen patch. And, in that sense, she was able to function to some degree. And she had pretty good health habits. Her work was, she was a movement disorder trainer. And by the time she entered the study, she wasn't confident to take on new patients. She had this fatigue where she could only work in the morning, even though she slept 8.5 hours. She could only work in the morning. In the afternoon, she had to nap. She ate well. She exercised, but she didn't do any vigorous exercise or any resistance training at all. So we did screen people for their kind of enthusiasm for the protocol. So we had a pretty good idea that we were going to get good compliance. People would say things like, I'm going to be the best person in your study.
Yeah.
Maybe they were trying to make sure they got
Right.
in. I'm not
Right.
sure, but you know, compliance and enthusiasm, of course, are huge. And this woman was absolutely engaged from the get go, and she did everything. She learned how to do high intensity intervals. She learned weight training. She took our trainer very seriously and worked with him. And she was in ketosis within 7 or 8 days. And
Wow.
we had a book that we gave people. Deborah designed it where they had to keep track of every ketone measurement at least once a day, write down exactly what they ate, how long did they sleep, what kind of exercise did they do, and for how long. I mean, it was it was a pretty big time commitment to do all of these things that we asked of them.
Yeah.
Anyway, this woman was like I said, she ate well. She had a kind of a Mediterranean type diet and a lot of good health habits. But when we did her nutrient evaluation, she was low in vitamin D, she was low in a lot of the B vitamins, she had a low glutathione, and she ended up with high lead and high chemical toxins.
Hmm.
So she had a lot of things that needed treatment. So,
So
you know,
glutathione, just for listeners, glutathione, sort of so the body makes glutathione. It's an antioxidant. It's very important to help our bodies detoxify. So, if I'm hearing you correctly, and you're building sort of a picture that this particular person had a number of so-called toxins that were problematic, and then probably not an adequate defense system against that.
right. In the Recode protocol, we have these types. Type 1 inflammation. She had a little bit of inflammation, but not much. Her blood sugar stuff was fantastic. Uh, Type 2, she had some nutrient levels that were low. Her pregnenolone and DHEA were low, so those were replaced. Type 3, the toxic, like I said, she had a high lead and she had many of her chemicals were quite high. So we gave her an oral agent that chelates or helps the body remove lead, just a low dose, 3 days every 2 weeks, and then you cycle off of it, and you'll go back on the DMSA. And this very kind of gently, slowly pulls your lead out. Lead does tend to go up, by the way, in many women after menopause because when you have a lower estrogen, you lose bone mass, and that releases lead into the system, as Dr. Pizzorno taught me. Um, and so for her chemical toxins, that was the big thing. So we use nebulized glutathione. I like to use glutathione. You put it in this little device that you put the glutathione in with sterile water, and then they breathe in the glutathione into the lungs. And because the lungs have such a big surface area, you can get a nice glutathione level. She also took oral glutathione. So we did a few months of the nebulized glutathione, and then she went to nasal glutathione, trying to get a little bit more glutathione into the brain. And we continued the oral. She also got NAC and acetylcysteine, a very well established molecule, has been used in hospitals for years,
Hmm.
that increases your body's own production of glutathione. So those were some of her treatments. Those I think I've gone through most of her treatments. Um, and at the end of the study, her neurocognitive index, her what we call the CNS vital signs score, her overall score. She went from a 23 percentile to an 84 percentile for her overall score. So you can see why she's my favorite,
Yeah.
my
So
favorite
that's
patient.
yeah, again, just to simplify it, CNS vital signs. I know we talked about in the last episode, but that's a validated tool to basically look at a few different features of how the brain functions, right? And so this person went from obviously a low percentile at 23 up into the 80s, which is amazing. And can you comment on some of your non-successful subjects? Because that's certainly a reality.
Yeah, I mean, it really comes down to one word: mold.
Mm.
Um, I had two people who were living in moldy homes, one of whom was just extremely enthusiastic and very, very compliant for the first 6 months of the study. And I think when she saw that she was getting worse and not better, she kind of gave up. Um, she had, she did have a very high chemical on her chemical toxin test called propylene oxide, which actually came from her running her own home business for many years. She's a very smart woman, ran her own tax company, but she had a printer sitting next to her every day, all day, running. Turns out when printers run and the printer ink is being put onto the paper, that you aerosolize some particles, some of which are propylene oxide,
Hmm.
which is a toxin.
Hmm.
And she had 4 times the 95th percentile for
Oh
propylene
wow.
oxide.
And she
And she
was
was
still being
very,
exposed to that all the time, or that was a
no,
historic
no. Well,
exposure?
after we figured this out, she was no longer exposed to it.
Okay.
Um, and she did a very good glutathione protocol, nebulized glutathione, oral glutathione, nasal glutathione. But her husband sent me photos of their home. Their HVAC intake looked like a horror show, just fluffy
Oh,
mold,
oh,
just big white fluffy mold, and then black around. That was their HVAC intake. And then the room where she worked, her home office, they sent quite a few photographs of that. Black mold, thick black mold around every window.
wow.
And they did not feel that they could move out.
Yeah.
They did eventually find what they did. They taped off these areas of the house and they tried to clean them themselves, against my my advice. Um, and of course, she didn't get better. After the study ended, they did have a expert come in and advise them on home remediation. I did a virtual meeting with their home expert, and he was very, very good. He
Hmm.
really, knew what he was doing.
Yes.
And they had their home remediated while they stayed in it, which was, not my advice. But again, they just didn't feel like they had the money or resources to do anything differently.
I
And
think
that's
this mold thing is a huge first, and I think still it's still not 100% clear to me, at least, that mold. And I know I'm maybe in the minority in the in terms of those that are treating and looking for it. But there's clearly illness associated with mold as a driver for Alzheimer's. I know we sort of accepted that it is, but I would still, if you took that to the Mayo Clinic, Ron Peterson, one of the sort of the the on the Mount Rushmore of Alzheimer's disease kind of people. I don't know if they would agree yet that it's clear that Alzheimer's is at least in part driven by mold. But
Nate, when Ann and I went to medical school together, so we go way back. But then we actually took Dr. Bredesen's training at the same time, and I walked out of it saying, all this is really interesting. I love all the physiology. I'm going to do all that. There's no way I'm going to learn all that mold stuff.
Yeah.
And a patient convinced me, not in the study, but a woman who was referred to me for significant decline after a mastectomy. So I wasn't going to get to put her on hormones right away. And she was so incapacitated, her husband would come in the office with her. And when I said they had mold, and they'd already fixed the mold in their house, but they found some more and remediated it. And 6 weeks later, she was supposed to come back in for a follow-up, and she wouldn't come in, and she kept putting it off. I said, you have to come in. She says, I can't. I'm back at work full time, and I just don't have time to make an appointment with you and talk about all the ways that I'm better. And that convinced me. And every patient since then, was definitely the most dramatic. But if we have to accumulate the anecdotal evidence to convince Mount Rushmore, we'll do it.
Yeah, I've definitely seen people improve from treating toxins, from getting away from mold. That it drives Alzheimer's pathology, really. So we need, it just thinks, to be really convinced of that. We need to be and to be able to say to people, you need to move out of your house. I think probably a lot of people would react like Anne's patient, would be like, well, I just, I'm not sure that squares with the reality that I'm aware of, right? Like I can imagine that because right. We're asking people to do so much. So Deborah, that's another question for you. Like for the people that you were working with in the study, what can you kind of describe the biggest challenges? How were they successful in changing habits, and how long can people keep, if it's not second nature to someone and they weren't always an exerciser, were they able to keep these things up? I mean, you guys looked at these folks for about 9 months, right?
Yeah. I think I can answer that individually for each patient, just as you can for each patient in your practice. But let's just look at the nutritional challenge, because I've faced with a number of patients, because I think that's more accessible than talking about some of their more esoteric things. But I had 2 patients who were pretty much vegetarians. One person ate fish, which gave them a nice toxic mercury level. And I had 2 patients who had partial gastrectomies, which made it really hard for them to eat in a concentrated window and go overnight without eating and have a prolonged fast. And
so just for people that just to define a gastrectomy, please.
Right. They had part of their stomach removed, one of them for a benign tumor when she was young, and the other one for encroaching on his Barrett's esophagus as an adult. But I'd say the ones that were the most enjoyable to me were working with these 2 vegetarians, and I get to shout out a little bit to our genetics testing that we did. So I had this one lady who no family history of dementia, and when we tested her genes, she had 2 copies of the ApoE4 for Alzheimer's, which means it was running through both sides of her family, and nobody had it. So I was really curious to see her genetics. We used the company Intellex DNA and got really pretty comprehensive genetic cognitive related details. And she did not have the other 2 main drivers for Alzheimer's, but she had a couple of problems with methylation, and she had genes that showed that she had a very high need for choline. We all know, and I'm a big choline fan, that choline's really important for the brain. It's important for liver health. It's important for making ketones. And you can pretty much only really get it very significantly from 2 food groups, which would be egg yolks and liver. And she was a vegetarian who was allergic to eggs. I got her eating liver. I got my other vegetarian his problem was not an allergy or a particular need for choline on his genetics, but just that he was iron deficient from being a vegetarian for so long. And I said, come on, I've got some great chicken liver recipes. You can both do it. And the woman said, I've got the people at the co-op holding out the chicken livers for me. I get the freshest ones. I have them, she was eating them every day. I said, okay, that's enough. You don't need to eat them every day. No. But, I loved when together we could come up with some resourcefulness around problems that maybe we wouldn't have identified easily in a routine care practice, but I think contributed to their problem and then their resolution.
Yeah. And so that was somebody that improved as well.
Yes.
Okay.
And
Great story, Deborah. Especially perfect for you.
Yeah.
You gave them permission.
And how did you find the utility of the genetic testing in the study? Was it helpful?
Yes. We had the great luxury of knowing Sharon Houseman Cohen, who's the chief medical officer of IntelliX DNA, who was very generously met with us about every one of our study patients if we so desired, which was extremely helpful. I mean, she's done a huge amount of research on all of these genes and what's important about each one. Deborah mentioned that, I didn't know this before working with her, that if you carry the ApoE4 gene, that effect is mitigated if you do not have TOM40 or ApoC1. If you have normal TOM40 and ApoC1, that decreases almost to maybe an APO3 level, but not quite, your risk of Alzheimer's. So that's really good information to have, especially if you get it early on in life. It's very helpful. What else? There's a certain the thyroid gland we have two important thyroid hormones, T4 and T3. The brain, it turns out, has a separate gene for making a deiodinase, which makes T3 in the brain. Some people have a normal T3 level, if you just measure their blood T3, but their brain isn't making sufficient T3. So if you give them T3, sometimes that is an important factor in the brain functioning just a bit better. Now, the big prize in terms of genetic information came from a patient of mine who had an unusual presentation for his cognition, which is that he had memory issues kind of gradually increasing. He was my youngest patient. He was only 50 when he started the protocol, but he had kind of gradually increasing memory problems. But he also had this unique situation where after flights he would be very confused, and he was a guy who started his own IT company and traveled frequently internationally, etc. Very, very bright guy.
Yeah.
Had to call his wife after he got off a plane one time to come and pick him up. He couldn't remember how to get home from SFO to San Rafael. And he turned out to have 4 genetic mutations in coagulation genetics. Now, most physicians have heard about factor 2 and factor 5.
Can you
And he
explain that a
did.
little bit? Coagulation genetics, what do you mean?
Coagulation factors or coagulation genetic mutations would mean that your blood, typically they mean your blood clots too easily, clots too
More
quickly.
easily than others. Okay.
More easily than others, yeah. I mean, obviously we need our blood to clot when we cut ourselves, but his blood, he was heterozygous for factor 2, heterozygous for factor 5, but he also had this SERPINE1 mutation and an ANP mutation. So he was heterozygous, meaning one normal gene, one abnormal gene for each one of those factors. And altogether, when he went on a plane flight and he had a slight decrease in oxygenation, his blood was sludging throughout his body, and when it does that in the brain, it was impairing him. So there was a question, and still possibly a question, about him being on a prescription anticoagulant, but for the time being, he stayed on nattokinase and pycnogenol, and he's been fine on his flights. Now, there were no flights during the pandemic, but he did go on post-pandemic flight, international flight, because he's from Belgium originally, has family in Belgium, and he did fine.
Interesting. Right. So
So
interesting.
that was a genetic find that I don't think we would have figured out without the help of IntelliX.
Beautiful. Okay. Okay. Wow. So one of the things that we covered in the last episode, and I think I personally agree with, there's the usual care, which is kind of the diet, exercise, sleep, stress, right? Like those are I think nobody would, there's good evidence for those things, that they're healthy, they're health promoting. But what Dr. Toups was saying, what Kat was saying, is that there were a few other things that were looked for that made this particular approach unique, and that there was the addition of hormone replacement. There was toxins, like we talked about before, and then there were viral and infectious testing. And can you, and perhaps Deborah, after, can you talk about like why that testing was included, and to some extent how they were treated?
Well, herpes simplex virus type 1, there's very good research that shows that HSV1 is strongly associated with an increased risk of Alzheimer's disease. If you do post-mortem exams on the brains of people with Alzheimer's disease, there's lots of HSV1 in their brain as compared to people without Alzheimer's disease. And there's probably some association with HSV2, Epstein-Barr viruses. That whole herpes family of viruses appears to be a problematic set of viruses. And then there's good research out of Asia, I believe Hong Kong, that showed that if you treated people who had HSV1 outbreaks with antivirals, that you reduced the risk of Alzheimer's disease quite significantly. I don't recall the number, but I believe it was well over 50%, very significant. So we don't know exactly how to apply that. What's the right dose? What's the appropriate response when you find someone who has is HSV1 positive? So what we're doing is we're treating, in my regular practice as well as in the study, we're treating folks who show up positive with HSV1, whether they get outbreaks or not. We're suppressing that virus. And everybody does it a little differently because we need research to show what is the right protocol.
Yeah.
But we do have enough information to say, okay, giving antivirals is a good idea. Part of the reason we know that is because part of the reason why I feel comfortable with that, let me say, is that the valcyclovir, acyclovir, those have been around a
For the
long.
HSV, the treatments, the common
That's
treatments
the
for
treatment. Those are the antivirals for HSV1, HSV2.
Yeah.
They work very well. Um, I've had quite a few patients over the years who take an antiviral every day for 30 years because they carry the virus, usually HSV2, and they don't want to pass it to their partner. And that is successful at keeping the virus from passing from one partner to the other intimate partner. And that provides very, very good safety data. The fact that people can take this for 25, 30 years and have no side effect. There's very little problem with
Right.
taking these antivirals. So I typically give the valcyclovir for 2 months, and then I continue to give it, A, if they have an outbreak, and B, 1 week every month. That's just a protocol that I've adopted, but there's nothing in stone about that. And it would be great if we eventually get research that shows us what is the right dose, the right treatment protocol. But we
I
do
think
know
some
that
of the higher dose protocols, you mentioned Hong Kong, I think there's one in New York, that those are those studies should be completed. I don't know if COVID decimated those studies, but we should have. Those are like the 1,000 to 4,000 milligrams a day of continuously for many months. So we'll probably have that. More
Yeah.
information
Yeah.
coming.
The tricky thing for us in this trial, you asked that question, and as you were going through that litany of things, I thought, oh, right, for that patient, I addressed that toxin and that mold and that gastrointestinal infection and that viral infection. And yes, he got better. And there is definitely, I can see the appeal of doing a study where you test one thing at a time. But I love the appeal of this study where we got to do so much for patients. So we did a gastrointestinal test at the very beginning, a stool examination, and a couple of my patients had no symptoms but had a pathogen show up on their stool test. So treated them herbally, not with antibiotics, and replenished their gut flora with probiotics, and their levels of body inflammation went down. Was that the crucial part in why they got better? Or was it the fact that they were doing Brain HQ or had somebody having them work out with the trainer? One of the answers in my mind to the paradigm of that is what we're asking them to do once you get past the fixing part to the maintenance part is really not that different from what my lifestyle is like. I mean, I kind of eat that way. I don't test my ketones 3 times a day, but they don't either once they know what ketones they're making. They take more supplements than I might take, but I still take them. And then the hormone replacement therapy, I apply that principle pretty equally to all my patients. And I think we talked a lot about hormone replacement for women, but for men too, with my other vegetarian who is iron deficient, had osteopenia. And even though he had some prostatic hypertrophy, we figured out a way to give him some testosterone, which...
So he had thinner bones, you mean osteopenia?
Right. He had thinner bones. Even though he was a moderate exerciser, he became a better exerciser. One of the great things about the trainer we worked with is he had a sauna in his gym, and he invited all our subjects to come kind of at the same time before the pandemic. And so they had their own little group meetings and met in the sauna while they were all detoxing together. But I thought he had restless sleep, not really sleep apnea. He had restless sleep, thin bones, iron deficiency, low testosterone. And since he'd had a lot of belly fat, he'd probably been turning whatever testosterone he had into estrogen until we whittled away that belly fat. So put him on testosterone. And
Are there anybody that you wouldn't, were any situations where you wouldn't, or you wouldn't put somebody
Well,
on a
one of my
therapy?
patients had very significant prostatic hypertrophy. In fact, he had to have a
So prostatic
procedure,
hypertrophy, you mean like a large prostate?
very enlarged prostate that
Okay.
essentially was closing down his urethra. It was pressing inward and closing the
The
tube
ability to
that
go
the
to the
urine.
bathroom. Okay.
Yeah, and so eventually, right in the middle of the study, he had to have a catheter put in,
Oh,
and then he had to have a procedure. Um, and this is actually one of my patients who also did very well, an ApoE44 guy who initially had a CRP, C-reactive protein, which is an inflammatory marker of 7.7.
okay.
And I think I figured out later this was probably a lot of that was due to his prostatic hypertrophy. He was very inflamed because after his procedure, which he absolutely had to have right in the middle of the protocol, a version of a procedure to open up his urethra. His Both his PSA and his C-reactive protein dropped to 1, below 1.
Okay.
Um,
So very
so
normal to low risk in terms of inflammation.
right, exactly, and he did extremely well with the protocol. He's a guy who's wife was just like beside herself with his poor memory. And he would just say to me, that's just a wife thing, but his memory was tremendously better by the end of the study.
Oh, good.
He's a person who told me, I'm going to be the best patient in your study.
All
I'm going to do
right.
the best. And he had many bumps along the road, including having to have a catheter for 3 weeks before he could get his procedure. And but he stayed in ketosis. He had to modify his exercise a bit,
Yeah.
obviously. But as soon as he could get back to exercising, he did. And he was he did very, very well.
I think we ought to try and lean on that competitiveness that your patients exhibited and start running contests, because I had a couple patients who kept whining about things I asked them to do, and particularly ones who didn't have very compliant spouses. But if I said, there's a contest for the most compliant subject, maybe they'll do better in the next study.
It's a good idea. I have a lot of ideas for the next study, but
So
that's a
maybe we'll
great.
get to that. Maybe we'll get to that. But I want to stay on the hormone replacement for a second and ask a follow
Oh
up and
yeah.
then come back to you, Deborah. So hormone replacement, like estrogen therapy, testosterone therapy, potentially something like progesterone, DHEA. There's several. But estrogen, testosterone are certainly the most controversial. And like I mentioned at the beginning, you're a big proponent and kind of scholar of the literature when it comes to hormone replacement therapy. You've lectured a lot on this. Why do you think it's so important to give estrogen for cognitive recovery, especially since my understanding is the literature is mixed to some extent on estrogen therapy for cognition?
Yes, the literature is mixed, and the reason why the literature is mixed is because a lot of the research, you read the title of the study, and it's estrogen does blah blah blah. Um, and the really, really important thing, because lots of people send me, um, they send me the research. They say, Anne, how can you say that estrogen is good for the brain? Look at these studies that show that it's bad for the brain. And that's, they have a legitimate point. The problem is the studies they're sending me that show that it's bad for the brain are studies where they used oral estrogen and most often synthetic progestin. And those two things combined, especially if you give it to older women, and this would be, like a long lecture to go into why, but oral estrogen increases, we talked about clotting early, but oral estrogen increases inflammation in the body, increases C-reactive protein, and it increases fibrinogen and other clotting factors. And so you take maybe a 65 to 75-year-old woman. She's been off estrogen since menopause at age 50. You give her oral estrogen. During that interim, she's been at increased risk to develop cardiovascular disease because estrogen protects women from developing vascular disease until they go through menopause. Then you give her an oral estrogen that causes an increase in inflammation and an increase in clotting. And wow, you get some fairly negative results potentially as far as her vascular effects. And of course, the health of the blood vessels in your brain is critical to cognitive health, right? If you're not getting blood, you're not getting the nutrients, you're not getting the oxygen, right? So when we use estrogen, we use estradiol, which is the hormone that our female bodies make, and we put it on the skin, either a patch, a gel, a cream. And that has a very protective effect as far as your cardiovascular health. And we don't use the synthetic progestin called medroxyprogesterone. That's a very, very bad molecule, does lots of bad things. Estradiol increases mitochondrial activity in the brain. Mitochondria make all our energy. So you can see that that's going to be very, very important. The ability for your neurons and the other cells in the brain to make energy. So estradiol upregulates that. When you give medroxyprogesterone, it blocks that upregulation. So this is the critical thing, that when you're talking about estrogen and progesterone, you know what you're talking about, exactly which. Turns out the biochemistry here makes a difference, and that's really hard for many doctors to even get past that, let alone, your average person who hasn't studied medicine. And that's why every month I get questions from people. And look at these articles. Estrogen's bad. It's bad for you. Look at anyone who's interested should look at Whitney Wharton's 2009 paper on estrogen and prevention of Alzheimer's disease, because she lists the studies where they use oral estrogen, mostly Premarin, and she lists the studies where they use estradiol, mostly topical, and she shows the outcome. And the outcome in the list of studies where they were using topical estradiol, they're almost uniformly cognitive benefit. Then you look at Premarin, Premarin alone, mixed results. Premarin with medroxyprogesterone, really bad results, right? So that's hard to get through, because in the title and even in the abstract, when you're looking at research, they're not even going to tell you in most
Right.
cases what estrogen, how they delivered the estrogen. Was it to the skin
Right.
or
Totally.
orally?
You make all these points. These are excellent points here, and I know, because I've heard your lectures, and I would encourage our listeners to go back about 3.5 years and listen to the episode we did together. It's tremendous. There's so much information there, and you're always updating all of us on this. That I appreciate. We also did an episode with our colleague Felice Gersh a few months ago, talking about the potential cardiovascular benefits. Deborah, I wanted to ask you just to comment on your experience, especially as you're introducing people to hormones, and you give bioidentical. You talk about what Anne just mentioned and some of the benefits as we see it. Is there still sometimes pushback, especially for women who are, let's say, over 60, 10 years past menopause, outside some of the typical standard of care guidelines? Do you get pushback, and how do those conversations go?
Definitely get pushback. In the study, one of my patients had always assumed she couldn't have hormone therapy because she'd had DCIS, which is, when she had it, was considered an early cancer. Now we really consider it a pre-cancer, at risk for cancer finding in breast tissue. Not so much that she had breast cancer, but at that time she was told you can never take hormones. So I had to have a good talk with her about it. I have a patient in my practice who we gave her hormone therapy, totally fixed her insomnia, totally was helping her osteoporosis. She was not taking my advice about cutting down her alcohol consumption, and she got a little breast cancer. And her oncologist said, "You can't take hormones anymore." I said, "You need to meet my friend, the oncologist, Dr. Lamont,
Yeah.
who I'm sure you've heard of, and maybe some
Oh
of
yeah,
your
sure, done.
listeners
I know.
have."
Yeah.
And Dr. Lamont said, "Well, if you can monitor her in this way and that way, and if she wants to stay on them," and that's the other part I wanted to get to, "you better keep her on them, because you're going to keep her from breaking a hip and from, being awake all night." And also I talked her into drinking less alcohol. But
Yeah.
what I typically do with women who do feel resistant because their whole family is pressuring them, I either point out something they have that's either gotten better on hormones or could. A woman recently who said, "I need to go off these hormones." I said, "Well, just to review what they could have helped with you." And I added to the list that they could have been helping with her gum disease. They said, It was the hormones that helped my gums. My dentist wanted to know what I did for my gums. I said, well, it was the hormone. Anyway, so I talked to them about the things that could benefit them. And I say, give it a try for 3 or 6 months. And you have to be happy, and I have to be happy for us to continue them. And I haven't had a woman yet who didn't want to continue them.
Because the benefit is clear to them?
The benefit is clear to them. I'd say most women feel better, sleep better, feel as if they're thinking better. I'm aware that I think their metabolism is better, that it helps normalize, as Dr. Gersh pointed out in her article, estrogen's a great anti-inflammatory agent in the body. So I think it optimizes their health all around. So I think I have women in their mid to late 80s who are on hormones, and
yeah, absolutely,
quite happy with them.
Amazing. I want to go just back for a second, track back to some, we were talking about viruses, infections, and just, what have you lay out kind of the infections that you looked at and you looked for? We don't have to go into all the treatments, but I am curious to know what the infections that everyone looked for as part of the basics.
We'd have to pull out our protocol. We looked for herpes type 1, herpes type 2, HHV6, which is a different herpes, which we don't really know what to do with, but we believe it's quite pathogenic, so we kind of wanted to know.
Definitely associated with Alzheimer's for sure.
We looked for Epstein-Barr. We looked for gut infections. And did we look for hepatitis? I don't think we did.
Yes, we checked for Hep C.
We did check for Hep C, which is kind of, that should be part of routine protocol for people in this age group in general.
Yeah. How about bacteria?
We checked for syphilis.
Right.
We covered our bases.
We did check for syphilis, right.
And did you guys, how about other bacteria that you looked for?
Just really through the pathogens that showed up in the gut test. One of the things that I think Dr. Toups, Kat, wanted us to test for more that we did not was CMV, cytomegalovirus in the brain, and I think she might have even done that, snuck outside. The thing about this protocol, we sat down and agreed on the basics.
Basic testing, yeah.
And then it was in each individual's hands. So if somebody who's more of a vegetarian had a patient who had a high choline need, they might have given more choline supplements, which I did too. But me being who I am, I'm going to push liver on the people. So we had some leeway in how we worked out the protocol. The treatments. And, the patients demanded some of that as well, particularly some of them going through the pandemic or how the protocol affected their marital relationship. I'd say I only had one really enthusiastic partner and one near divorce.
Wow.
Deborah, we also checked for tick-borne diseases.
Yeah, I was going to ask about that.
Borrelia, Babesia, Bartonella, those three.
Yeah. Did anybody turn up positive on those for you?
Yes.
I think Kat said she had 9 out of 10 positive. I think I had 3 people who were borderline. One, and I think I treated them all with an herbal protocol that included the Beyond Balance formulas for all of mine were Borrelia positive, the Lyme, the bacteria that's responsible for Lyme. And then I added Cryptolepis because of its, it was shown in a study to be very, very, very effective on getting rid of the persister form of the Borrelia bacteria. Borrelia, these diseases are very, very complex to treat.
Yeah, no, I hate when I hate when I have to check, and I hate when I have to treat. But you gotta do it.
That was the most difficult part of the testing because. So one of the differences for the whole study is I practice in a very semi-rural area, and Anne and Kat practice in a really urban area. So it was harder for me to find the resources I need. So to even find somebody who would draw the specimen in such a way to send it to the labs that were the testing that cooperated with the study, that was a challenge. And as I said, one of them came back. I don't know what, it got sent to them on time. It came back at 9 months. And I treated as well 3 patients with herbal tinctures. And when they don't have any, so I am no Lyme expert, as you and I were talking about a little bit earlier today. When somebody has no reaction at all to the herbal tinctures that I'm giving them for Lyme, and they can ramp up the drops. So we start out with a really low number of drops, maybe 1 drop once a day, and you want to get up to maybe something like 10 drops twice a day. And if they never have any trouble with it, there are Lyme disease doctors who would say, well, then they don't have Lyme. And it makes me wonder if they really had it. And I didn't see any harm from the treatment nor any real benefit in the ones I had.
Mm-hmm. Okay. That's an interesting observation. So I guess, when you take this whole thing, we could talk about, details, and part of me would love to just go on and on. But clearly one of the criticisms that we've talked about amongst ourselves, and that will no doubt be, criticism in general of this kind of approach, is the complexity, the difficulty in checking everything and doing all the recommendations, etc. Of course, people are, particularly outside the context of a clinical study, patients can choose to do whatever they want. They could stay in a moldy home, and they don't stay in a moldy home. Like they could come to see you, they don't come to see you. But but at the end of the day, there was pretty clear improvement. So, do either one of you have like an intuition about what kind of the key things were? I think everybody agrees change. Go on a good diet, exercise, sleep, stress. I mean, those are inarguable, right? There's trials going on that are sort of doing those elements with coaches and looking at things like Fitbit and Pacific Neuroscience Institute's publishing papers on that. And I'm curious to know if you guys have intuition what you think the key things were. I'm sure it includes the lifestyle elements, but I don't know, Anne, you want to start?
Yeah, absolutely. Being in ketosis. I mean, I don't know in my regular practice, I don't know how many people I see them or end up talking to them a month later and they're not measuring their ketones. It's extremely common. We spend a lot of time on it, and people don't want to prick their finger. Um, but
You
I
prefer
think,
to do a blood test, like an AccuCheck, like a you prefer the blood test as opposed to urine strips, just something that's might be easier for someone.
yeah, I don't believe that the urine is accurate.
Yeah.
My understanding is that the urine is accurate early on as you're getting into
Mm.
ketosis. You're gonna see some form of ketone there. Although the great thing now, I'll just side step over to say we now have a breath meter that is very reliable. Dr. Bredesen's group has tested out the BioSense breath meter, and of course, people are thrilled to be able to switch over from finger pricking on a daily basis. And using it, and not only that, but those ketone strips are expensive,
Oh yeah,
and if you're
$3
if you're
per strip.
checking twice a day,
Mm.
which we do encourage people early on. I encourage people early on to check twice a day at least, because you might be low in ketones in the morning and high 2 hours after dinner. People are surprised by that, but with the BioSense breath meter, you can you can check your ketones 10 times a day if you want to.
Yeah.
It's nice and easy. So that's a great addition, and I think in the next study we'll certainly um, be able to use the BioSense breath meter for most folks, and maybe double check it with a finger stick blood test once in a while. Um, and I also think exercise makes a big difference. In my patient, who she was a regular exerciser, that the woman I talked about earlier, she was a regular exerciser, but she weighed she weighed about 150. Um, her BMI was just very close to 25, just a little under 25. When she started doing weight training and high intensity intervals, along with keeping up her regular movement exercise and hiking that she liked to do, She dropped her weight to 139. Her BMI went down to 23, 20, high 22. She was more muscular. I think that high intensity exercises is essential. Um, uh, in most folks, and many people who are regular exercisers don't get that. They don't have the high intensity piece in there. Um, you know, some kind of brain stimulation, beyond, stretching your brain a little bit, beyond what you normally do, is probably uh, important for most folks in terms of recovery. And then if you're stressed, absolutely you need to do stress reduction. And sleep, oh my gosh, if you have sleep apnea, it's over. And it's been surprising to me because I check everyone for sleep apnea. We have a pulse ox device that we uh, rent out to folks, and most physicians will tune into someone if they're overweight that they may have sleep apnea, but you find many thin people with sleep apnea.
It's many.
So my patient in the study, who he had sleep apnea, he knew it at the outset. He lost 45 pounds and no longer had sleep apnea by 6 months into the study. But in my regular patients, I've had a couple of times people have a very significant recovery. I've had two wives call me to say he got the CPAP, he started using it, and his brain came back. He's like almost normal,
Yeah.
from
Yeah.
being quite impaired. So sleep apnea,
We have the same observation.
you've
Same
got to
observation.
find it. You've got to find the sleep apnea, and you've got to treat it. Those are probably, from my point of view, the most critical things. I think replacing the B vitamins, giving enough choline, um, you know, in some folks, maybe the whole coffee fruit extract. These are some of the supplements. We did put people on a lot of supplements in this study. We haven't really mentioned that. And that's part of the concern about how this transfers over into real world, is the expense of everything we did, the massive amount of testing, and the massive amount of supplements, and the cost of all the personnel involved in making it happen. But I think proof of concept is important, and my hope is that we will start to have people coming in earlier. Too many
Right.
people who come to me for cognitive impairment have been impaired for 5 or 10 years.
Right.
And what we really hope is, by getting the word out, getting the study out there, that we create an environment and awareness among doctors and among the general public that, hey, take care of this right away when it starts, because it is reversible. Way more easy to reverse this if you find it early. Not only that, if you have a parent with dementia, get on a protocol early. Or if you know you carry an ApoE4 gene, start thinking about this, learn about this, and do the things you need to do to prevent it.
Absolutely.
Yeah,
Um,
I think Anne's points are really good about that. I think I heard your interview with Dr. Bredesen and Dr. Toups was really great, and I agreed and disagreed at the same time with something Dale said, which was that these are highly specialized protocols that we took them through, and you need these highly trained, specialized doctors to do it. And I would really like to think that everything that Anne just described, with some caveats, like which I'll say about in a minute, everything that she just described, a good family practice doctor theoretically could do. They could understand that you don't just tell somebody to go for a walk every day. You have to be kind of specific about exercise. You don't just tell someone to eat a Mediterranean diet. You tell them what that means in a brain context. So, but it really is accessible through pretty conventional and certainly Medicare covered lab tests and dietary choices. And that covers a lot of improvement people can get to. And when you get to the areas of difficult mold infections, gut infections, Lyme infections, certainly that's an area of treatment that would require someone more specialized. So what I would like this proof of concept to do for the medical world is to open up the possibility that there's different, just as in your practice, if you had somebody with high blood pressure and you tried a couple interventions and it didn't work, you'd send them to a cardiologist for further evaluation or for some management of why this is so difficult to manage. And similarly, if we had people with high homocysteine or mild cognitive impairment and their family doctor did everything we would have started with, and they walk into our office, then the task is better laid out as to they're going to need something more specialized.
Yeah, I agree. Some people will get better with, a metabolic approach, optimize their cardiovascular health and their blood sugar and their exercise and their sleep. But then there'll be those people who have, a couple of high chemicals and a high lead, and then they need some more intervention to get. I don't think my patient would have really gotten better if we didn't pull her high lead down and treat those chemical toxins that she had. So it's a combination. It would be great if all primary care physicians were at least well trained in the lifestyle parts of this protocol, for example.
Yeah. Right. I mean, just what you said about, you're a big proponent. I've go for a bike ride with Anne, and she disappears for 30 seconds at a time as she inserts her intervals into the bike ride that you're on with her. And then we'll go out to the gym in my garage, and I'll want to lift some weights. So, both those are important parts. You can't just tell somebody to go for a long walk every day like they do in those slow motion Prevagen commercials. They need to understand what the details of a healthy lifestyle are. And so to that extent that it was really laid out for us in the protocol, we instructed people on all the three different aspects of exercise. We didn't just tell them to go for a walk every day. But really, that's all handleable in a comfortable conversation between a knowledgeable physician and her patient.
Could probably be like a knowledgeable health coach or a dietitian.
Yes,
I mean, I don't know why it has to
exactly.
be a physician from a lifestyle perspective. Really
You
doesn't.
are right. You are right. But it's easy for the physician to write an order and for Medicare to test the lead and mercury levels to just know that they don't have anything else they have to or their homocysteine levels. And then you're right. Health coaches can be very valuable in the future of handling this disease.
So, I mean, so you mentioned, I think we mentioned some of the criticisms. I think anything from the study that we haven't sort of covered that you, either are critical of or would maybe do different next study. I know I have
Well,
ideas.
the obvious criticism is no control group and only 25 patients in the protocol, which I think Dr. Bredesen and Dr. Toups talked about those things. But I think the other major criticism we've kind of been talking about, I think, which is the tremendous amount of work required for each one of these people to get them through this protocol, not just by we physicians, but by the entire team and the patient. It required a huge amount of the patient and the patient's spouse or study partner. And some of the spouses were really gung-ho and into it, and some of them were a little bit a little obstructionist at times about it. So I think that it's hard. That's the main thing. I think that's the main criticism when it boils down to it. The protocol is hard and it's expensive to do it thoroughly in the way that we did it. And so we have to find some of these things we've just been talking about at least, primary care doctors being able to, initiate the most basic parts of the protocol, take a look at that and understand it and help people with it.
Yeah, no doubt. No doubt. And just sort of to follow up on that, do you think there's anything that was unnecessary, or you might think is unnecessary for a next trial?
Right, not that I can think of. Which doesn't mean we're going to have any more free time when the next one starts.
Well, we'll set up our protocols so that it's easier to track everything.
That would be better. We do need we learned a lot about trying to get a more efficient software support of the data that we're gathering along the way.
Any last comments from you guys? We talked about a lot. It's been an hour and 15 minutes. We'll probably have to just split this one up. But again, congratulations on the release of the data. Hopefully that it will find its way into a peer-reviewed medical journal soon. And we look forward to hearing more from both of you guys.
Yeah, I mean, we're hoping in 2022 to start the next study with 100 patients and have a control group to get rid of, that piece of the critique of our study. So I'm excited to move forward with that, and just continue to move the needle on this topic and make Alzheimer's disease a rare disease.
Amen.
It's pretty amazing to tell people about this study, and sometimes their eyes glaze over and they go, yeah, you helped people. And then other people go, oh my goodness, that's remarkable. I go,
Yeah.
Yes, you got
people
it.
that know, people that know understand that this is remarkable.
That it's remarkable and very exciting. And I'm so glad I went to that conference at the Buck Institute half a dozen years ago.
Yeah, absolutely. All right, guys, thank you so much.
Okay, thank you, Nate.
So that's our episode. I hope it was useful to you. Check out the show notes on iTunes or on our website where we've summarized the key points. If you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. If you have questions or comments, connect with us on social media. Finally, to support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show. That's Patreon, Patreon, patreon.com/evolvingpast. Thanks, and talk to you next time.